Good morning, everyone. My name is Tyler Levitan. I work as a policy and research specialist with the Canadian Federation of Nurses Unions, the CFNU, and we're excited to have been supporters of this really important partnership and really grateful for the incredible research that's coming out of this. Yes, I am honored to be representing CFNU here to moderate this session. Dr. Sheri Price is a professor in the School of Nursing at Dalhousie University. Her research is focused predominantly in the areas of nursing work environments, health services, and women's and community health. So why don't you go ahead, Sheri? Thanks.
Thanks so much, Tyler. Sorry with that. We threw you a curveball.
No worries.
Hi, everyone. My name is Sheri Price, professor at School of Nursing at Dalhousie. I've been working with Ivy for quite a long time, since my postdoctoral work. The title of the presentation you can see here today is I Feel Broken, a Chronicling Burnout, Mental Health, and the Limits of Individual Resilience in Nursing. So we will present two papers. This is the first of the two, and there's some overlap between this and also what Ivy presented. So I'm going to move through some of these slides quickly. So in terms of background, nursing burnout is not new. We'll go to the next slide, Kim. It's really well documented for anyone out there in nursing or outside of nursing, but COVID-19 obviously just exacerbated that. And there is this notion within the nursing literature that individual resilience is one way to combat that, but it really doesn't address some of the systemic issues that are deeply embedded within the structures. So in terms of our method and methodology, I'm going to present this, and this will save Kim from covering this, but it was, as Ivy alluded to, was a qualitative descriptive approach. And we did one-on-one interviews that were semi-structured because we knew some of the quantitative data. And so we really wanted to be fluid in terms of understanding and delving a little bit more deeply into some of the findings we found there. As Ivy also covered, we used a framework of intersectionality and gender, and I think that's our next slide, which I won't go into, but you can see that there are several levels that we're exploring. So the societal, the work organization, also the family and individual level, which are combined within our presentation in terms of findings. Next slide. So our samples, you can see we had 53 nurses, and that's the breakdown there, 34 RNs, 6 LPNs, 1 RPN, 7 NPs, and 5 undisclosed, and predominantly female, 46 of the 53. So our key findings, really the overarching theme is breaking points. People were pushed to a breaking point, and these breaks happened at the individual, organizational, and social and societal level. So our first theme focuses on the individual breaking point. It really was, as again, we've discussed, and we will probably have some repetition, it has to do with the gendered nature of nursing, being a predominantly female occupation, and that balancing of caregiving in the home and work. People were really concerned about their family, at the same time concerned for their patients, and they felt that there were unrealistic expectations of what they were doing, and this work was highly emotional. And there were often opportunities that they could have intervened or had somebody intervene or help them, but those cries for help were unmet, and people were pushed to a leave of absence, but did identify that there could have had help earlier at several interjections, but wasn't offered. You can see in the next slide a few quotes. One registered nurse said, "I think what pushed me to take that leave of absence was I couldn't take care of myself outside of work anymore, that I had given all that I had to thrive and work in this environment. When I went home, I had nothing else, and I just would stay in bed." And a nurse practitioner shared, "I was trying to keep from everybody that, nothing was happening, trying to maintain being myself. So there wasn't the stress. There was the stress of trying to act like everything was okay." So you could see that it was something that people didn't want to openly share. There was some shame associated with that, and also fear of letting down your coworkers. So that leads me to the organizational level and the unit level. breaking points. And that was really that burnout is somewhat normalized. It definitely is normalized within nursing. You're almost indoctrinated into believing that burnout is going to be on your career trajectory. And as a result, I mean, when it's normalized, it's perpetuated. In addition, there's been shortages in nursing for decades, and that was further exacerbated during the pandemic. And there was no time to take even vacation or a sick day because they were so short, and people were not offered an opportunity to have a day off, which led to them feeling that their cries and concerns were dismissed, and that they felt there was a real lack of managerial concern for their well-being and their mental health. And it was almost an environment of, well, who isn't struggling? So suck it up. As you can see with the next quotes, I can tell you in the last year, I've encountered more of my coworkers crying in corners than I have my entire career. Many, many times over, people are spent, they're done. They don't have energy or the fight to keep going. And another participant said, even if you're working crazy amounts of hours for the last 2 years straight, you apply for vacation and it's denied. And so they're not able to regenerate. So the next level of breaking points occur at the social and societal level. The pandemic was stressful on everyone, and nurses have been the recipients of overt incivility and violence at times. And this was, again, just heightened at a time when people had great uncertainty. There were people questioning protocols and questioning whether or not some of the procedures were needed, and were non-compliant with it and took that out on nurses. There was also a lot of judgment and confrontation about things like visiting family members. So they weren't just dealing with very sick individuals and concerned about their family and not being able to take time off, but in addition, banging pots doesn't do it all, but just to have people be overtly judgmental and having this impression that it was okay to do so in society. You can see from the next quotes that one participant said, I'm tired of human behavior here, and people forget that with rights come responsibilities. And people were talking about individual rights, and not just anybody who is anti-vaccine, but they were saying that there was a lack of concern for the communities at large. And that the other participant here says that the climate in healthcare has changed. People aren't happy when they come in, and you take a lot of your time reassuring them and trying to make them happy, and then take abuse in the end. I think there's one more quote that I think I have in the next slide that highlights that, yeah, you're being aggressed at. So this, again, brings to the forefront the violence, like that you're attacked in multiple ways. So maybe not physical, but aggressive behavior when people don't get what they want, or they come in and think that they know what you should do. And nurses are receiving this at a heightened amount since the pandemic. So in terms of what do we do with these findings? Well, I mean, in nursing, we've certainly been called heroes, but that superhero narrative doesn't really serve anyone well. And it doesn't acknowledge that we're not superheroes, and that, there's not a magic within us that enables us to deal with this. We also have to have realistic expectations of nurses, and also recognize the dual roles that they have, including the implications of gender. That's at the individual level. The next slide highlights at the organizational or unit level is we really need to resolve these tensions, and the tensions are largely between leadership or management in terms of what the expectations are between nurses' obligation to care and also service. Nurses and units need to be adequately resourced, and when I say nurses need to be resourced, they need to have resources available to them to help them deal with some of what they're struggling with in terms of their mental health. And our participants also highlighted that they needed strong leadership, and that they felt the most support from leaders who had an understanding of nursing or were nurses themselves, and also female. Next slide. Again, at a high social, societal level, there needs to be not only attention to issues, because we hear this in the news and we've seen this, and our unions do a really good job of bringing attention to this, but we need that call to action be responded to. by policy and having legislative changes. And if we're talking about who needs to be resilient, I think our organizations need to look at organizational resilience. And I think we have a couple more slides just talking about, I love this quote, we owe healthcare workers more than our gratitude. We owe them an urgent debt of action. And again, the interventions, as you can see, this issue is multi-level, multifaceted. So therefore, interventions have to be responsive to that. And we have to look at beyond the individual. And some of what we're doing with our next slide is we're moving beyond the individual by trying to come up with interventions, as we will all speak to today, that don't just support the individual, but support the unit level, support a societal level intervention in our toolkits. And Kim and I are also with Ivy leading a study looking at how can we reanalyze our data to interrogate those narratives for some exemplar cases, because we've heard a lot about what works well in terms of supporting our nurses by building compassion and enabling environments. I think that's the end. I think we're going to save questions. Thank you, Kim, for being my right-hand person. And I think Kim's going to go next, and we can field questions at the end.
All right, so good morning and welcome. I'm delighted to present our other paper from the worker interviews entitled Nurses Navigating Mental Health During Uncharted Times, Self, Other, and Systems. This paper has just as of Monday been accepted in the Canadian Journal of Nursing Research. So there we go. As we all know, the COVID-19 pandemic has been unprecedented in scale, having significant burdens fall disproportionately and inequitably on our frontline healthcare providers, further exacerbating long-existing professional inequities. When we sought out to do this study, we found that the existing bodies of research largely considered burnout as gender neutral. This is surprising and problematic, provided the significant difference between the gendered experience of work, coupled with, specifically for our case study, nursing being a predominantly female profession. We also know that pandemics have historically exacerbated structural gender inequities by further intensifying pre-existing asymmetrical divisions of household labor. So we sought to approach this work through a gendered lens. Findings I'll be presenting center on a substantive theme of navigating it alone at a variety of levels. The analysis provided recognized that health systems are gendered, and these findings sought to center nurses' narratives within these larger structures of gender-based inequity. Participants explained in detail how they felt they were left to navigate alone at work, at home, and within some of those broader social systems. I'll highlight the first two themes from this presentation. However, the third theme is described in full in our publication, which will soon be in press. So these are the three, so at home, at work, and in systems, and I'll speak to the two bolded ones. A considerable number of participants spoke candidly about the isolation they experienced as they navigated workplace challenges and the ensuing emotional burdens which have only multiplied as nurses have shouldered exceptional levels of personal and professional uncertainty and loss during the pandemic. One participant with an extensive and varied career spoke unreservedly about the cumulative traumas that occurred during her career as a registered nurse. She described navigating these emotional traumas in isolation without any institutional recognition until eventually she could no longer manage. She told us, "There's very little support and understanding to exactly the emotional toll that nursing work, can take. I've had some very traumatic experiences and they, the employer, just do not understand that." Other participants explicitly voiced a lack of support from administration and institutions, and particularly relating to the pandemic. Participants did comment on what they felt was the superficial and performative support provided by managers and administrators. But when they really needed mental health supports, they were incredibly difficult to navigate and not effective. Inadequate support was a common finding, which led some participants to go it alone and navigate their mental health supports and leaves on their own accord. These are but a few of the many stories we heard from nurses who navigated the workplace alone. Nurses also expressed feeling alone at home as they navigated disproportionate caregiving responsibilities in the home, both preceding but notably amplified during the COVID-19 pandemic. Nurses described the additional pressure of having to navigate their family's well-being alongside their own mental health and the toll this had on their own abilities to cope. Some participants highlighted challenges relating to the unequitable responsibility of coordinating childcare. For example, one participant told us, "My husband continued to work outside of the home and I worked inside the home. It became my primary responsibility to figure out how to care for the kids and continue to do my job. It was on my onus to have to describe to him or convince him why we needed someone to come help take care of the kids for some periods of time, because it wasn't possible for me to be meeting their demands as well as working." These inequitable caring responsibilities also involved family members. One participant shared, despite not having her own children, she became the default caregiver for an extended family member and actually required unpaid leave to care for him. I did want to highlight that the male participants that we spoke to did not report the same level of care-related expectations and responsibilities in the home. So what have we gleaned from this data? The increased demands and deterioration of workplace conditions have amplified the physical and emotional strain on nurses. Participants felt alone in navigating their own mental health and well-being. There's been a lot of emphasis in the literature, as Sheri has mentioned, on the need for nurses to demonstrate resiliency and much attention on self-care strategies. However, this discourse of nurse resiliency can actually reinforce the harmful belief that mental health is solely an individual experience, thereby disregarding the need for supports at the organizational and systems level. Expecting nurses to simply be more resilient is not an effective solution to the multitude of challenges they face in the workplace. A shift to developing organizational and system resilience is needed, which entails ensuring workplace structures and human resource supports are put in place to support all employees. Organizational factors such as the culture of the work environment, communication, and support from management significantly influences the mental health of health professionals. Supportive work environments and the cultivation of open and transparent communication between administrators and employees is essential. Enhancing social supports provided by colleagues and managers is critical to ensuring a positive work culture and has been proven to counter the effects of work-related stress. An important catalyst to create this kind of culture is increasing the amount of nurses at system-level decision-making tables. Nurses are currently grossly underrepresented in these roles. So many of the nurses we heard from highlighted events in their work that unfortunately lacked compassion as it related to their mental health, often from peers and managers. A minority of participants, however, did share moments in which they experienced compassion at work when struggling, and how this compassion absolutely impacted their experience in profoundly positive ways. Feeling enabled through being supported was also highlighted as a lacking necessity in nurses' work lives. In light of these particular findings, our team did secure a CIHR grant to explore, so re-examine some of this data around how compassionate communities and enabling environments can be harnessed to better support nurses' psychological safety at work. And many of you have participated in our recent policy dialogue relating to that study, which we're really grateful for. And we'll be reporting those findings from the study soon. So thank you very much.
Great. Thank you very much to both of you for those really wonderful and insightful presentations. I'm very excited to see that research, the study that was done on enabling environments and compassionate communities. I think that's really innovative and wonderful. I just want to emphasize how important it is, this research that focuses on the narratives and amplifies the voices of nurses directly working in the field and experiencing these really troubling working environments and lack of support in the workplace. So I think that this research is just especially important in providing those voices a bit more of a platform and a narrative for those important stories to come out and to, we sometimes get bogged down in statistics, and I think it's compelling from like a qualitative research, policy, and advocacy point of view to be able to put those narratives forward and make that as a central focus of the work that we're doing. So I just want to say that I do really appreciate this important research in these papers. And I would like to now pass it on to the discussant for this session, who, my mistake, it's not Matt Kelway, it's Dr. Rosie Yoon from the Toronto Metropolitan University, who's a professor in nursing and also with the RNAO. So I'll pass it on to you, Rosie. Thank you.
Thank you, Tyler. And I just want to echo what Tyler just beautifully captured. And I'm a nurse practitioner, and prior to that, a nurse for the last 20 years. And when Kim and Sheri were speaking, what resonated profoundly with me is your work, both of you, really captured the voices of frontline nurses really struggling. And what they were struggling with is exactly what you were mentioning, the intersection of societal gender norms, crushing with organizational, structural, systemic barriers playing out in people's lives. And so, and what's powerful in your research is many of us as nurses, if you, yeah, like you said, aren't at the tables where we can voice our leadership, aren't, and when we talk about structural gender norms, they've been around for eons. So how do you even dismantle that? And so I think your research is extremely powerful as a vehicle to highlight that work. And my area of work is really in how do we change organizational cultures to align with trauma-informed values where people, connection, and belonging really support psychological safety. And I feel that in taken for granted norms, lots of our healthcare system, a lot of our societal structures are built on gender blind norms and often on cisgender norms, cis male gender norms. And so in terms of organizational culture, your work spoke to people identifying, articulating this desire and need for organizational support. It would be nice if I could have support from my supervisors. And often what I find mind-numbing, also frustrating, is when we're working in structures that seem normalized, it's hard to see a different way out, a different way of doing things. And so I wanted to kind of bring to space for discussion, how do we move away towards a different ways of working? And I think, the pandemic has really highlighted and mental health as being vital. It's not an extra, but it's vital to workplace safety, and employers having a responsibility in that. And what I find complex in the nursing profession is you add another layer of gender-based inequity, and I think that space is quite difficult. And I think the elephant is in the room is gender-based power differential. And so when women identified nurses are really struggling, you talk about the breaking points. The breaking points is the collision of both system, society, org playing out in people's lives. And what really resonated with me is your quote from one of the participants saying, they feel like they have nowhere to turn. And so perhaps, my hope is, organizational cultures, really starting with awareness through your work. I think the power of your work, Kim and Sheri, is that it brings to situational awareness our blind spots, our taken for granted norms. And then once we, highlight our blind spots, you have an opportunity to choose differently. And I think we're at a watershed moment. I think nurses, I think uh, Matt, I'm going to take liberty as an honorary member of the RNAO, that I think we're at a watershed moment where nurses are saying, pot clanging and the hero speak and the you're so resilient is not going to take us through anymore. And I think we're at a pivotal moment where we can do something and we can change. So um, I see Sheri, so I'm gonna
Yeah.
stop talking.
I just thank you so much for that. There's a few things that you said there that I just didn't want to lose. And I have a really bad habit of holding my hand up. But I do notice a few questions in the chat. I didn't want to run out of time without addressing them. I mean, the first being Susan asking, yes, I mean, intend to leave. Do participants tell us that they want to leave? Yes, that isn't new either. That seems to be a constant steady state, but the ability to leave is a privilege afforded to very few. Leave to go where? And if you are the primary, income earner in your home, or even if you're not primary, it's very difficult to leave. And then where do you go? So we've known for a long time, nurses have a stated intent to leave, but whether that translates into attrition, it doesn't always. But then you have somebody who doesn't feel they can be there anymore, and that's very unhealthy. And I'm just looking at sorry, there's another Susan just asking about space. And I love that you asked that question, because I know that some initiatives have looked at how do we create the space, and this actually speaks to comments made in the discussion section, just about how do we ensure that there's not stigma and blame and shame associated with taking care of our mental health and having issues associated with our mental health. And there's been some strides, let's talk, but our organizations have to really walk that talk, and that talk has to be evident in not just the party line of, the mission, vision, and values, but we really need organizations to care for those who care, or care can't take place. And we've heard from nurses having the opportunity to, and when I say embrace, it's not even physical, but it can be just one another, and have being able to openly discuss, being able to take some time. We have a code lavender, and that's been something acknowledged in the literature. Code lavenders are a call for help for our health professionals to say somebody is in need of help in this immediate moment. Let's find a space for them that they can have some support. They can have a buddy, somebody who's there as a support person to help them. So that really does matter, having that moment to step away and process what you've just experienced, especially given the emotional turmoil and the compassion fatigue that we know is associated with care, not only during the pandemic, but in healthcare in general. I don't know if you have anything to add there, Kim, and I noticed there's a couple more questions.
Yeah, absolutely. So what comes to mind is I think what we need to do is just sort of dismantle a lot of these taken for granted, that even with cold lavender, if you think of when that first came to be, people were like, well, you can't just stop nursing and have a conversation. Why not? What is it about, unless a patient is in crisis, you can step away from the bedside, but that needs to be enabled and supported. And it needs to be okay for nurses. We have to create spaces, and leadership plays a huge role in this, in saying it's okay if you need to step away from the bedside to work through something that you've just witnessed or that you've experienced. Because we do have that all or nothing. I'm here for 12 hours. I have to go, 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 go. And there isn't space, both physically and metaphorically, for nurses to work through that on the spot. It's taken home. And then at home, there's no space, and it accumulates. Yeah. And in terms of space, I saw a question about physical space. If you think of some of the break rooms, they're old patient rooms, or they're closets. So we don't have spaces that support wellness for nurses in hospital infrastructure, in the architectural designs. That's something that there's a small group of nurses who look at architecture, but there's big opportunity to be forward thinking in how we create spaces that support wellness, not just for patients, but for the people who spend their entire work lives in these spaces, whereas patients are rather transient in comparison. Yeah.
Yeah, and I noticed Matt also added, yeah, we strongly believe we have to move past that concept of the individual's resilience. It doesn't address everything that's going on. It puts it on the individual. And we need to look at how we can support individuals so that they don't have to cope, they don't have to build resilience, so that we may actually intervene before they have mental illness, and so they don't need to take the leave of absence. And again, I'm really excited for this secondary data analysis that will mine these narratives for those exemplar cases, because I think that this tale has been told time and time again, but we need to come up with solutions. And as a nurse myself, I know that nurses often have the solutions and have insight into what they need. It's that we need to listen and we need to respond. Does anyone else have any questions or comments for Kim and I? I think we did a pretty good job of going through the chat, but if we missed you, we apologize, and please do. Both of our papers are well, one is in press. I failed to mention the first paper I presented is published and accessible and open access, and the CGNR is coming soon.
Will the CJNR paper also be open access?
I believe it is, yeah.
Okay.
Yeah, because it's through Wiley, so yeah, it is.
Wonderful.
And we just want to mention in closing that we also have a stakeholder paper. So we interviewed stakeholders as well. And so we have that paper that we will be preparing this summer and publishing that. So that's still to come. Thank you, everyone.